Hello and welcome to the Headache Doctor podcast, where on this podcast, it's our mission to educate and empower everyone with headaches and migraines so that you can break free from a life of fear of your next headache or migraine and dependence on medication. In today's podcast, we're going to highlight that fear component. Our mission is to help people get out of the fear of their next headache or migraine. But what about the fear of something worse going on? The pain and the symptoms that people experience, they're strange and they're intense. And so it's natural for people to wonder if they have something like a tumor or a stroke or some sort of infection, these scarier things that are kind of behind the scenes. So this podcast is, largely driven by Dr. Thomas's interest and desire to get this information to you, the listener. So Dr. Thomas will be kind of taking the lead. Thanks again for joining the Headache Doctor podcast.
Yeah, I'm excited to be here. I thought it would be fun. I was trying to think of a Halloween episode or something of some sort. And I think it's really common to attribute really serious symptoms, as migraine and headache symptoms are. I think it's very common to attribute them to something bigger than just a migraine or a headache. My aunt used to have a kind of a book called The Encyclopedia of Everything That Would Kill You. And you read it and then you start thinking like, oh my gosh, my knee hurts and I have a tumor and I'm dying. And I think we want to move people away from that. And we were doing this podcast today really to educate people that while there are occasionally underlying causes for headache and migraine, we want to educate people that they're pretty rare. And so that's kind of what sort of fueled this podcast today, is just good education and kind of helping people calm down that fear component. So today we're going to talk about tumors, stroke, meningitis, and CSF leaks as kind of four of some of the underlying causes of headaches.
Yeah. And so entering into this conversation, there's two objectives. The first objective, in line with our mission, is to educate and empower. So that empowerment means that we're going to talk about these very, very rare, scary things, but with the understanding that you should leave feeling empowered and not like, oh, I have one of these things. The chances of you listening to this and being in one of these categories is like almost zero. I've been doing this. Novera's been open 6 years. And I have yet to find someone in one of these categories. And the reason for that is largely because, one, the patient doesn't necessarily either have the time or even the intuition to say, I need to look up a Headache Doctor podcast to solve the problem. The problem feels different, and usually it's more of an acute thing. Like it's something that needs to be addressed pretty quickly. And so accessing healthcare, entering through our healthcare system, via the primary care doc or emergency room, they're very good at catching this stuff. And so generally our healthcare system doesn't lead people confused when they're in one of these categories. But it's helpful for us to talk about them so that your mind can be put at ease potentially. But again, we're not. So the second thing is, don't use this as a way to diagnose yourself. And so we don't want to be you don't want to be using a podcast to basically discern, okay, is this a tumor? Is it not? That sort of stuff. Like you actually want, like if you have a gut feeling that something's wrong, then you need to get looked at is the point. And don't use this podcast in that way. But for most of you, our hope is to put your mind at ease. So yeah, any other words before we jump in?
Yeah, no, just the empowerment, just to echo what Dr. Taves just said, just the empowerment. I always encourage my patients that you know what is best for your body. So if you do feel that your symptoms are serious or you just want that peace of mind, please go to the doctor, go to the ER, get checked out. I want everyone listening to this just to know that you are the expert on your body more than anyone else is. So yeah, just the empowerment. But other than that, I'm ready to talk about tumors.
All right. Yeah. Ready
Tumors.
to talk about tumors. Let's talk about tumors.
Yep. So brain tumor, it's probably the most common worry when people start kind of getting new headaches. I think everyone just goes to brain tumor. Cancer is very, I think, present in our society, and we're all very worried about tumors. So brain tumors are actually quite rare. They can be primary or secondary. So you can have a tumor start in the brain, or you can have a tumor form kind of as an offshoot of cancer somewhere else in the body. And they can be benign, which means they're just kind of a casual growth of cells that's not going to do anything harmful, or they can be malignant, which means they will be kind of inclined to spread. Now, headache is fairly common with brain tumor. It's about 50% of cases, and the symptoms are fairly diffuse. They can be painful. Usually they're most painful in the morning, but they can be painful at any time of the day. You can have pain with like coughing or straining, that sort of thing. And then as far as other symptoms go, you can have pretty much any litany of symptoms, and it just depends on where the tumor is. So for example, if the tumor is more toward the back of your head, you may end up with visual disturbances. If it's more kind of in the middle or off to the sides, you may end up with a lot of like sensory type stuff. If it's in the front of your head, you may get a lot of personality changes. So it just kind of depends. As far as symptoms go, pretty much it can cause about any symptom, just depending on where the brain it hits. So as far as if you should worry about tumors, primary brain tumors are considered very rare. They are about, I think the average incidence in the population is about 0.0075%. So one out of very, very few people, or I guess very few people are going to have a primary brain tumor. And they do share some symptoms in common with migraines. So for example, the pain, the headache, even some of the visual disturbances and even the weakness, stuff like that can definitely be attributed to migraines. And they've actually been able to prove that some brain tumors don't cause any headaches. So just because you have a brain tumor does not automatically mean you're going to have headache. And the reverse is also true, is if you are a migraine sufferer, it doesn't put you at any more risk of brain tumors. There's really no correlation there.
Yeah, that's great. To give an overarching sort of, we zoom out and we look at how headaches and migraines are diagnosed. There is that primary and secondary category to any type of headache. And so when we talk about most headaches being in the primary category, I've talked about that before in the podcast, but the primary headache means like there's nothing there's nothing like else that we can attribute the headache to. And I don't want to go off on a tangent, but sometimes that's true. I think when we're talking about the neck and how it's overlooked, like that technically would be secondary, but we miss that. But in this conversation, this would be a type of a secondary headache, meaning there's something that's occupying space in the head that's causing pain. So the tumor type headache is also generally never going to necessarily change. One thing that most people we have that with their headache, it'll be worse at a certain time of day. It'll onset at a certain time. They'll be able to change it, or they'll see an increase or decrease depending on their inactivity. So it's not as if like if you have a headache related to some sort of like tumor or something that's occupying space in your head, generally it's not going to be as responsive to those things. It's just going to be like it's always there. Nothing ever changes it. And so the way that someone communicates that pain will be different. We also see a lot of people that have daily symptoms. So don't take anything that was said there as indication of like, oh, maybe this is something like a tumor. Because you mentioned, okay, if it's in the back of the head, it could be like a visual disturbance or something. A lot of people we see have visual disturbances. Nothing wrong as far as like tumors or things like that. So there's going to be overlap in some symptoms as well. Don't take you hearing a little bit of like your story in that as like, oh, panic. Because like we said originally, chances are very small. And as a provider, dealing with someone that has head, neck issues all day, every day, it's pretty easy to sniff out when someone's communicating their symptoms and that feeling like this is different. And like I said, patient intuition is usually there as well. So tumors. Anything else on tumors?
No, I think that about covers it. Yeah, the only thing I would just like to stress is they're pretty rare. And if I can push on your neck in the clinic and I can have that pain shoot up into your head, it's probably not coming from a tumor because we're finding it in the neck. So a lot of our patients, it's very easy to reproduce their symptoms. And obviously, if it's coming from the neck, it's probably not a tumor in the brain. So yeah, the next one, if you're ready, I was going to talk about stroke. This is probably the second one that people are worried about. This really doesn't tend to be the patients that we see at Novera, or again, probably the people listening to this podcast, because if you have the time to find a podcast while you're having a stroke, it's probably a little bit questionable. So there can be two types of strokes. You can have an ischemic stroke where blood basically gets blocked to the brain, so like a blood clot or some sort of like just like a breakaway. And then you can have a hemorrhagic stroke where there's some sort of a rupture and there's bleeding within the brain. And this kind of the stroke symptoms can vary as well, but they tend to be the stuff that I think there's been quite a bit of education on these in the past. So, you get stuff like facial drooping, slurred speech, weakness on one side of the body, a really bad headache can come on. And they say, I think it's like the acronym FAST, if I remember. And then the last one is time. You have to just get your keys and go to the hospital or have someone take you to the hospital. So if you listen to that, you can really look at that and say, wow, there's quite a few of those that are, again, quite similar to migraines. Migraines present with headache. They also can present with like a hemiplegic migraine where half of the body is pretty weak. So as far as worrying about stroke, if you really don't have headaches and suddenly you are getting a lot of weakness on the side of your body and you're getting this terrible headache, that is cause for concern. And that is when it's time to go to the ER pretty much immediately, because brain cells are dying one way or another. And that is something that you need to address. So if you do start noticing these symptoms just coming out of nowhere, again, slurred speech, facial weakness, drooping, weakness on one side of the body, sudden terrible headache, it is time to go to the ER. But if these have been more chronic symptoms and stuff, you're getting that head pain all the time, you're pretty used to getting that weakness on the side of the body, it's not as much of a cause for concern.
Yeah, that's huge. And I think it's a pretty, it's a confident test of, like you said, the time factor. If this is something that you've dealt with weekly for the past like 10 years of your life, because that's a lot of people we see, it's like decades worth of symptoms. The changes from a stroke that are happening to your central nervous system are going to be pretty quick. If those neurons aren't getting oxygen because blood flow has been restricted to them, or whether it's hemorrhagic, meaning there's a brain bleed, that's when that really strong, immediate sort of thunderclap headache will come on, especially if that's like an artery that's just like pumping blood into your head. That's a matter of hours. And so you're not listening to this podcast. I can pretty much guarantee that. And then ischemic stroke is that sudden blockage of a blood vessel getting blood to that part of the brain. And that's where like the traditional signs are there. And that's why time is important, because the longer that those cells go without oxygen, the higher risk of there being long-term permanent damage, things like that. So stroke I feel like it's a relatively easy one for people to feel confident of, like, okay, these are stroke-like symptoms, but we went to the ER, they did all the screens, nothing's happening. If you're leaving the emergency room and they've checked for all this stuff, yeah, you can feel confident like they checked, and you're probably thinking, okay, let's dig deeper and understand what else can cause these symptoms. And that's what we do. That's our role, is picking that up.
Yeah, exactly. I think most of our people that have, especially the hemiplegic migraine, where your kind of part of your body does get weak, most of them have gotten to the ER right away because they do think it's a stroke. It's, it definitely is something you want to rule out. And that's one case. I think we talk a lot about the medical system on this podcast. That is one case the medical system can be really helpful, is going to the ER and making sure something serious isn't going on. But most people will go the first time that they have one of those migraines. They'll realize they're not having a stroke. And then after that, if it does become more chronic, then that's something we can start sussing out at Novera.
Awesome. Okay. So what's next?
Okay. Meningitis. This is an interesting one. I actually did not know this. So, I know the anatomy, but the brain sits basically in a pool of fluid called your cerebrospinal fluid. And then that fluid is encased in a series of membranes called meninges. And so meningitis is inflammation of either the meninges or the fluid. And this is the part I didn't know. It can actually be caused by a variety of things. So it can be bacterial, it can be viral, it can be fungal, or it can be parasitic, which the idea of parasitic meningitis that's Halloween fodder right there, if I've ever heard it. So you can get an infection. Most of the cases in the US are viral. And meningitis is an interesting one that, depending on the severity of it, it can be something that just kind of goes away on its own, or it can be like, we need life-threatening treatment immediately, or life-saving, I guess, treatment, not life-threatening. That would be bad. So symptoms of meningitis, some of them overlap with migraine and some of them don't. So some of the ones that do, you can obviously have headache. You can have a stiff neck, which is a pretty characteristic and diagnostic symptom of the meningitis is the stiff neck. Again, most of our people come in with a lot of neck stiffness because we found it to be their headaches to be tied to the upper cervical spine. But a couple of things that don't tend to pop up in migraine is you're typically running a fever because it is an infection within the body. You may be experiencing seizures, and you may also see a skin rash as well. So meningitis is a fairly easy one to differentiate from our people. Again, if you don't have headaches and you suddenly have a really high fever and a stiff neck and a headache, that's definitely time to go into the ER and make sure you're okay. But most of our people are not experiencing the more serious symptoms. So while meningitis is a cause for concern and something people will talk about and like, oh my goodness, did you share a drink and get meningitis? It's a pretty easy one to differentiate from migraine.
One of the interesting things with meningitis is we've actually had a handful of patients that had meningitis and it resolved, it was treated effectively, and then they presented with headaches or migraine symptoms after. And the idea there is the meningitis, whether it's like the illness, the virus, the bacteria, the fever, that ill feeling that puts someone down, that maybe causes their musculoskeletal system to then just take on a little bit more stress, or the fact that they feel stiffness in their neck, so they've actually like stopped moving. Maybe they have a prolonged forward head position as they're working through that pain and the virus and the bacteria, and so there's an impact mechanically, like physically, on the neck from someone going through this process that we've seen impact them later. So if for some reason you've dealt with that and it's like it's treated, there's no history of this in your system, or there's no current evidence of this in your system, but you're starting to deal with headaches or migraines later, there could be a mechanical component that's fixable that was just not directly related to the virus or the bacteria, but because of the impact of like that experience, if that makes sense.
Oh, yeah. And that can be the same. And we've seen COVID kind of trigger that as well, that there can be a lot of times that some sort of a serious illness does trigger sort of the migraine, the inflammation and migraine cascade in patients later down the line. So that definitely would be a patient we would like to see, though, is the meningitis is gone. It's been treated. So we just need to treat those underlying causes.
Yeah. So are those the three big...
One more.
Okay. One more.
One more.
Yeah, let's do the
one more nightmare, right? So CSF leak. So again, the brain is sitting in a bunch of fluid. So if those meninges, you'll remember the membranes that hold in the brain and the fluid, if there ends up being a hole anywhere in those meninges, that can also be cause for headache. Those holes can be anything. It can be from trauma. It can be from a surgical procedure like an epidural. It can also just come on its own. That is pretty rare. It's about 0.001% of the time, I believe. But it is occasionally does happen on its own. So if you do get a leak of that cerebrospinal fluid, you can have a headache. Symptoms of this, again, you can actually get meningitis from this leak because, you've got suddenly a mixture of fluid. It's in an environment it's not really supposed to be touching. So you can actually develop meningitis from having a leak in the cerebrospinal fluid. You can also have tinnitus. You can have headache. You also get, this is an interesting one, but you can actually start getting a nasal drip. So if you start to suddenly notice you've got a headache and you've got one-sided, just constant clear fluid dripping out of your nose, it's probably time to go get checked out. You do need a doctor to be able to tell you, differentiate between that being just a normal sinus drip and a CSF leak, but that can be a cause for concern as well. Again, pretty rare on these ones, the incidence of just, no trauma, no surgical procedures, that sort of thing. This happening is very rare. But if you have had a recent surgery or a recent car accident and you're suddenly developing this headache, you should definitely go get checked out.
Yeah. And this is, this wouldn't necessarily be in the category of emergent, immediate cares needed, but it is something that would be underlying that our medical system would need to address. And we'd want to address in a timely manner, but different from, a tumor or a stroke, or where those are like, life-threatening and potentially relatively quickly. CSF leak, I guess, generally is going to be, you'll see the signs and symptoms of it. They'll run the test, and then they'll go through the process of treating it, but it doesn't need to be like days generally. But it's just something in sort of in the back of a physician's mind as what we call like a differential diagnosis. And if symptoms aren't really like matching up, and if it just seems to be a little elusive, this is something that usually pops up and we look to test for. Yeah.
Yeah. And it's one that, that's another patient that's not going to respond super well to our treatment. So again, if we're starting to do treatment and seems like there's not really a lot of a response, that might be something maybe we would screen for a little bit down the line.
Yep, absolutely.
Okay. So the last part of this podcast, I just wanted to cover basically the red flags of headaches. So again, migraines always feel like they're pretty significant. They are stressful. It's scary. So we wanted to just use this last section for just basically kind of a catch-all of when it's time to either go to the ER or call your doctor and just basically get immediate care. So I'll kind of give the symptoms, and then Dr. Taves is going to explain maybe why not to worry as much as needed. Yeah. So first symptom is just if you ever have just a sudden severe out of nowhere headache. You don't usually get headaches, but you suddenly have just the worst headache of your life, it's time to go to the ER.
I would 100% agree with that. I mean, obviously headaches got to start somewhere, and a lot of people we work with go from relatively few or no headaches to a really bad headache. I'd qualify that with like, if you have a history of headaches, and that's almost like any frequency of headaches is, I would say, abnormal. So 0 headaches to like a really bad headache is definitely a cause for more concern. But if you go from like, oh, I get an occasional headache every month, and then you have a worse one and it feels like what you experienced just a lot worse, less concern there. But yeah, any new onset of symptoms, especially if you're worried about it, is worth getting looked at.
Yep. Next one is if your headache is kind of accompanied by a lot of other symptoms. So especially those stroke symptoms. So slurred speech, trouble with memory, trouble with coordination, loss of balance, confusion. If you're seeing a lot of other symptoms that, again, unless this is your pattern, if that is just how your migraines present, because we do have people that present with aphasia where they have trouble speaking during a migraine. But if you suddenly get a headache kind of out of nowhere, or you've gotten headaches before, but suddenly this one is accompanied by a lot of other neurological symptoms, I would definitely go to the ER.
Yeah, we've seen all sorts of neurological signs and symptoms that match all the things that would be scary. So just the fact that you have other neurological signs and symptoms isn't necessarily a sign for concern. It's really just the newness of symptoms would be the main thing. And if something feels new and like, I haven't had this before, and you have like, okay, I want to get this looked at. Yeah, don't necessarily shove that down. Like you can act on that. I think that would be wise.
Yeah. And next one is, and this one, again, migraine. We've had people come in that have had migraines for straight weeks. So this is not, again, another just immediate, I guess, cause for concern, but it can be a red flag, is a headache that gets worse over a 24-hour period. So it builds after 24 hours instead of kind of starting to slack off, or that you go more than 72 hours without 4 hours of pain with 4 hours without pain. So if you go 72 hours and there's been no decrease in pain whatsoever, that would be a cause for concern, or potentially could be.
Yeah. This one feels like we could probably, I'm just thinking through all of our, like the different scenarios and the types of patients we see. And this one would probably qualify.
It's like everyone,
a lot of people that we see. And so, that presentation in my mind isn't like, oh, this is an alarming thing, but, yeah, cause we see a lot of people that have that presentation, go to the doc, go to the ER, they don't find anything. But again, sometimes hindsight's 20/20. And so like, we're not seeing the people that had those signs and symptoms and they actually found something. And so our data might be a little skewed, but again, if that describes you, not necessarily a cause of concern, unless it, again, like a new thing, something that, you're like, oh, I've never had it this bad, but like that sort of stuff.
Yeah. And going along with that, this is also going to kind of capture a big net of people. But if you do have the meningitis symptoms, so stiff neck, fever, and then nausea and vomiting. And again, most of our people, if you've had migraines, you've probably had nausea and vomiting. Your neck is probably also pretty stiff and painful. So the real differentiating with this one is fever for me. Yeah. Obviously, our chronic migraine sufferers are not coming down with fevers. Right.
Yeah. Interesting caveat here. You could, when our body's fighting off like a virus or an illness, and you have a fever, oftentimes that manifests itself like with COVID. It was pretty common to have like body aches and pains. And so if it causes your neck to flare up and you're like, oh, I have a fever and my neck hurts and I'm vomiting, that like most people in that scenario wouldn't think like, oh, now I have meningitis. And so going back to your like encyclopedia of everything that can kill you, there's a way that you have all these symptoms doesn't mean you need to be in a panic state. And so it would definitely be like, the fever would be absent of any other illness. Like you don't know why you have a fever, why your body aches, why you have chills. And it just feels like your neck is stiff. So,
yeah, definitely. I think most of these can be pretty much people we've seen or some sort of a similar presentation. One that is a good one to know about, and this does have a caveat, I'll let Dr. Taves answer too, but if you have a sudden headache right after a trauma, so you get in a car accident, you fall, that sort of thing, and within like an hour or very short period of time, you've got a really severe headache, that's a good time to go in and get checked as well.
Yeah. Again, we have a lot of people that have a history of some sort of trauma, car accident, whiplash injury. We see it's not uncommon for people to have onset of a headache after those experiences. And it could be hours, days, it could even be months later that you develop those symptoms. The idea here is potentially either there's some sort of trauma, whether it's to the neck or to the head. Maybe it caused swelling or some sort of reaction, whether it disrupted blood vessels or it's just like a concussion response. So like an intense headache after some sort of trauma, that should be looked at. We want to clear, screen both the neck and the head. Most people after a car accident, if they haven't had an x-ray, we definitely want to make sure they can turn their head all the way without pain. We want to make sure there's no pain to pressure over the bony parts of the anatomy in their neck. And so there's different screens that we would take someone through. But again, generally this isn't something like if you have a car accident and you just like have this really bad headache, you're going to want to get it checked out. Not many people are going to think, oh, like I listen to this podcast and this is just my neck. Definitely don't think that. You want to get that looked at.
Yeah, I'm hoping if you're in the middle of a huge medical issue, you're not going to our podcast.
Yeah, exactly.
Hope you're going to the ER. Last one I'll cover is just if you do have a cancer history and you suddenly have a new onset of headache. Again, we mentioned that those brain tumors are pretty rare, but they can be secondary. So if you had like breast cancer, for example, it is it's possible that tumor has popped up in your head. So if you do have a history of cancer, even if it's in remission and you're suddenly getting new headaches, that would definitely be a good time to go either to the probably ER or just your oncologist would probably be a good person to consult for that one.
Yeah, absolutely. I would agree with that. And even when we have patients that have a history of cancer, that's something we're thinking about. We want to make sure we can reproduce their symptoms, that they're seeing progress, and that it presents the way that we would expect it to present, which again can still be very weird and still feel very scary and still be like, a bit of mystery to it. But we've done this enough and we've seen a lot of weirdness that we know what doesn't fit even into our weirdness category. And so we can sniff out pretty quickly if someone is presenting with signs and symptoms of something that is not a neck problem, not something that we can help with.
Yeah, and that's about it. I feel like most of our other symptoms, there's really nothing else to cover as far as that goes. So my goal with this podcast, again, and I'll just stress one more time, is that most headaches are primary. Most headaches do not have an underlying cause. Most headaches do not require an emergency trip to 911 or, emergency trip to the ER. Most are just a headache, and often one that can be improved by improving that neck mobility and the stuff that we talk about on this podcast. So I hope this has done a lot to kind of dispel the fear around headaches. When those really severe symptoms come on, your chances that something is going on that's really severe are pretty small.
Yeah, absolutely. So two things for you, the listener. One, if just have faith in our healthcare system catching this stuff because they're pretty good at it. And I would say the whole premise of this podcast is finding the stuff that they don't find. And as these statistics show, it's like 99.9% of people that they're not actually providing an answer for, but this small percentage of people, it's fantastic. Like, you don't want to work with us if you have this stuff necessarily. And we wouldn't want to work with you. We'd want to send you to the right provider that can get you the help you need. So that's number one. Number two, is really the factor of time. Most of these things are relatively time sensitive. As time goes on, we would catch this stuff. And so a lot of our patients have been dealing with headaches or migraines for decades. And so when someone comes in and they say, I've had this recurring migraine every week for like 15 years or since I was 10 years old or something like that, that alone is usually enough for me to say, like, there's a very, very small chance that something is like underlying outside of like just an ongoing neck problem or jaw issue or shoulder tension. And so those two things should be comfort for most of you listening to this podcast, because I'm guessing that most of our listeners fit into that category.
Yeah, you usually don't find our podcast if this is an emergent thing. And yeah, if it's been going on for 15 years, the meningitis would have gotten you by then.
Yeah, exactly. Well, Dr. Thomas, thank you so much.
Yeah, happy Halloween, everyone.
For our spooky podcast. Very appropriate. And yeah, as always, it's our mission to educate and empower everyone with headaches and migraines so that you can break free from a life of fear of your next headache or migraine and dependence on medication. We'll see y'all next week.